Thanks for having me for lunch and to discuss the surgical management of musculoskeletal tumors, which really fall within the sarcoma program of this institution. And I had lots of help in getting to this point. And while I've never inhaled, I've also never taken any support for this lecture. There are a couple fill in the blanks that I couldn't, I don't know if you got paid, but I didn't. As impossible as it seems to me, I'm going to try to give you a little bit of information about the scope of disease that I encounter, how we evaluate it, and then what we do with it. And let me begin very quickly with scope, and for many of you this is just review. I just want to remind you that bone does of course contain bone cells, and at the ends cartilage cells, but it also contains practically any other cell types that you can think of, and all of those can form either benign or malignant counterparts that get treated by people like me. And the same is true of the soft tissue sarcomas. There's another area of neoplasm that I encounter that occurs far more often than anything I've put up on this slide, and that is metastatic disease. You know where it comes from, I know where it goes, and how we handle that and how we diagnose it is also part of our program and things that I want to share with you. Most of the time I'd like to spend on how we evaluate these lesions, and while it's a lot of fun to show you pictures of how I treat them, and I will do some of that, the evaluation is really where the rubber meets the road. It's a team approach. That team is represented around this auditorium and includes a wide scope of people that are interested in the intellectual, social, economic, as well as medical conditions of these patients at times of crises. You know how to work them up in terms of the names of the different steps we go through, and I'm not going to repeat that. What I want to focus on, and I'm going to digress a couple of times, and this is one of them, to talk about biopsies. Something you probably don't do as regularly as I do, although certainly bone marrow biopsies are part and parcel of your expertise. But I'd like to speak a little bit about biopsies. A mentor of mine once said, "Never hurts to know what you're treating before you start." And for an orthopod, that's an epiphany, and well worth keeping in mind. Another one of my mentors, Dr. Mankin, almost 20 years ago, looked at the complication rates of biopsies. And by complications, he really meant things that changed the course of treatment. A biopsy complication was something that impelled us to do something different than we might have otherwise. Not so much the infections that you might get from a biopsy, but when they were misplaced, misdirected, misinterpreted, and ultimately required us to do something that we would have preferred we could have done differently from the outset. And that occurred in his study, as he put it, about 17% of the time. It occurred more often at institutions that weren't used to treating musculoskeletal neoplasia. And when, after a great deal of education on his part, to the orthopedic community, he repeated his survey. He actually found the complication rate had not changed very much. But the point is that who does the biopsy, where the biopsy incision or needle is placed, can make a lot of difference in the alternatives we have to treat those patients. What they really are alluding to, my colleagues Dr. Enakeen and Dr. Mankin, are the biopsies primarily in this instance. They were talking about open biopsies. Those are procedures generally done in the hospital, often under some form of anesthesia, where you get a reasonably large sample and you give it to John and his colleagues to tell you what's going on. The other way this is done is a needle biopsy that can often be done in the office. Sometimes it's done by the radiologist, and more often than not at this institution nowadays it's done by the radiologist under CT control and provides a small but hopefully sufficient sample. And I do want to digress a little bit. The success of this procedure depends not only on the skill of the person doing the biopsy, but the experience of the pathologist with small samples, keeping in mind that sampling error, taking a piece of tissue from an unrepresentative section of the tumor can be frustrating, and the location of the lesion dictates whether I can do it in the office or whether I need to refer it to one of our interventional radiologists or musculoskeletal radiologists. Because I told her she had to do something scholarly before finishing the program, one of my residents decided to get even and look at my experience with needle biopsies. Clever person. And over this 6-year period of time, the service had done about 120. Most of them were office-based, which meant I did them, and a small percentage were done by our radiologist that will get lumped into this as well. And what we found was that about a third of these biopsies led to diagnoses that didn't require an operation, either benign disease or something that is better treated by you guys than me, or not together, lymphomas, things of that sort, that get irradiated, but did not lead to an opportunity to see the histology of the lesion any more than we already had from the needle biopsy. The other 2/3 had a procedure and we had more feedback. What we did, actually, what she did, she classified these as neoplastic or non-neoplastic. What she really meant was they were either diagnostic or not. And by diagnostic, we meant that the pathologist said this is A or B or C, emphatically, no wiggle room. Non-diagnostic meant that they either used the phrase suggestive of or they used descriptive terms, inflammation, or some other mechanism for saying they didn't know. Almost 90% of the time, our pathologists nailed it. They said this is what it was, and every single time they were correct. Of the 11 of those 82 that there was some waffling or some difference from a definitive diagnosis, it is really what I want to share with you today. 2 of them suggested malignancy. 9 of them, as I said, were explanatory but not diagnostic. Both of the suggestives were positive for malignancy, the malignancy they predicted. And of the non-diagnostic biopsies, generally the terms were inflammation or some other form of non-aggressive process, if you will. 6 of them turned out to be malignant. And depending on which denominator you want to use, the 11 or the 9, that's still a high number. And the point is, it's very important that the biopsy be done by someone who knows where to place it and can give it to a pathologist who knows how to deal with it, and in return to a team that knows how to be skeptical when you don't get a result that is definitive, because some of those results turn out to be neoplastic and important. One other dilemma I want to share with you in working up patients. I was told not to move around much because this is being photographed, but the good doctor here obviously has his eye on the patient and looks deep in thought. And as I investigated it, he actually wasn't thinking about that young person in front of him. He was thinking about someone he saw in the office earlier in the morning. And if you're an orthopod and you try to pick the disorder you want to see the least, that in fact is what happened. Someone walked into his office and said, "My back hurts, back pain." Well, my guess is that there's probably somebody in this theater right now who has had back pain or is having it. And if I'm not so bold as to violate your confidence, has anyone ever had back pain? Some folks. And it wouldn't surprise me if your back, like mine, hurts right now. The dilemma is why. Okay? 99+% of the time, it's for something totally mechanical and, from your point of view and mine, harmless, benign, frustrating, painful, but not something that's of interest to this group. And in fact, this patient walked in with an x-ray that was absolutely normal. Now, if you're really looking at this carefully, you notice that that is such a superb x-ray. It's a specimen x-ray. All the soft tissues have been stripped away. You couldn't take a better x-ray. But in fact, it is riddled with metastatic disease. And that's the rub. How do you separate out that unusual patient, numbers-wise, for huge group of, we're talking about tens of millions of people in this country with back pain. And even though it's a small percentage, it's a significant number that have an underlying malignant disease, aggressive disease. And figuring that out, sure, we can take an x-ray, and I've showed you that only takes us so far. We have MRI, we have CAT scans, we have PET scans, we have dog scans, we have all kinds of stuff to help us from an imaging point of view to get to the answer. But we really don't have a system that in any meaningful way would apply those kinds of studies to the first time someone walks in with back pain. But I just want to tell you from an orthopod's point of view, one of our diagnostic dilemmas is being smart enough to continue to evaluate patients with back pain and find those few percentage but numerous people who need to see you. And so I just want to add that to my list of dilemmas in the evaluation process. I promised I'd talk a little bit about treatment. I've got to. The two options we really have surgically are what I would lump together as limb-sparing procedures, those procedures that after removal of the tumor result in complete resection of the process, and for which there is a functional reconstruction. And that reconstruction can be, in this case, it's an allograft, a donated human bone that looks like the removed part of the skeleton. And I can tell you, in the right circumstances, this is a very gratifying reconstruction, biologic. When it works, it comes with a long-term warranty, or a metal replacement for a part, also becoming extremely popular, leaves the arm and the leg otherwise intact, while there often are muscles removed in the course of completely excising the tissue. It may not function perfectly, but by and large, very, very gratifying results. And it turns out if you adequately and completely excise the primary tumor, the recurrence rate, the local recurrence rate, is no different in limb-sparing resections than in the other alternative, which are amputations. But what we have to do is have a reasonable sense of anatomy, where the important structures are, and correlate that with where the tumor happens to be, so that when we draw a dotted line around it, depending on its aggressiveness, the nature of the soft tissue envelope may vary, but we have to understand that after we draw the dotted line and truthfully follow our intended incision, that we are left with a functional limb. And in, I'd say, well over 90% of the time today, we can do that. There are times when the lesion will incorporate a neurovascular bundle. We can replace arteries and veins when necessary. And while we can replace nerves, our track record at doing so functionally lags behind blood supply. But that is possible. And there are nerves that are important but not critical, that can be sacrificed in the course of a limb-sparing resection. But there are times when the disease is so florid, so aggressive, so pervasive, that we're left with amputation. And I want to tell you that for many people, an amputation is really a step forward, and it's the quickest way to get back to the things that are important to you in many cases. And I would encourage you not to put this on a list that really means it's a total failure, we didn't have anything else to offer. Sometimes a well-planned amputation in conjunction with systemic treatment is the quickest way to not only improve someone, but to cure them. And so we keep that in mind. And I have a little bit of time. My last digression. far more often than the primary diseases that affect bone and the musculoskeletal system are the metastatic disease. And I just want you to know that I also understand our goals of improving their life, and very often that includes an opportunity to try to remove metastatic disease with the idea not just of palliation, but sometimes even cure. Our challenges are that the bone loss, when we're talking about skeletal neoplasia, tends to be progressive. What you see today is probably going to be partially destroyed or gone tomorrow, and we have to keep that in mind. I also have to keep in mind what you do to them. The chemotherapy and the irradiation also alters the biology of repair of bone and soft tissue. And these patients, as you well know, are really sick. Some more than others, but they're anemic. They're prone to thrombi. Their ejection fractions are miserable after adriamycin. Their chest's full of metastatic disease sometimes. They have hypercalcemia of malignancy. They're more susceptible to infection, and their nutrition tends to stink as well. So we're starting out with a group of patients that need your support and mine, and we need to keep that in mind as we develop treatment plans. Getting back to the spine for a moment, there are opportunities to inject vertebral compression fractures, whether they're osteoporotic or neoplastic, with some bone cement. We do that here, and it often can shorten the time period of aggravating and incapacitating back pain, something to keep in mind. But the other area that we talk about amongst ourselves a lot, you and I, are the lesions in bone and the concern about fracture. Sometimes we see patients because they fracture, but often they're under our observation, and we see things that ask the question, is this going to fracture? Because if we can fix it prophylactically before it fractures, we save them the event of a fracture and the disadvantage in losing some momentum. And trying to decide whether they're going to fracture or not, I've lumped into three different approaches. One, for lack of a better word, is scientific, and there are people who've made scales that if you have a lytic lesion versus a blastic lesion, if it's in an upper versus a lower extremity, painful, not painful, if you add up the points you get out of those systems, you can correlate that when you get past a certain number, they're more likely to fracture. There's the other end of the spectrum, the art form. In Connecticut, when I was a resident here, which was a while ago, there was a Connecticut law that said you're dead if a physician said you were dead. Well, we've changed that law, actually. But sometimes in the clinic, a resident asks me, is it going to break? And I say, well, if I say so, it's going to break, and that's why we're doing this. They don't let me get away with that very much. And what I really tend to use is an approach that talks about a substantial amount of the bone being involved. This was pre-MRI, pre-CAT scan. But the point is a substantial amount of the bone, especially the cortex, is involved. And I think the single most important factor is pain when they use that bone. If it's in a femur or a tibia and every time they put their leg down it hurts, that's Mother Nature yelling in their ear and yours, yes, this is on the verge of fracture. You can have a big hole in the bone and no pain, and it's a coin toss. It really is. Then it gets back to art form. But if you've got a patient who hurts when they stress that bone and it's got a lytic lesion in it, even if it's relatively small, I'd like a call. And I think I can help. Again, I have to keep in mind that how I help reflects the fact that neoplastic malignant disease is progressive. The distance time-wise between these two x-rays is about a year. And this is metastatic breast cancer, and here it's fractured, and here it's going to. And we have all kinds of things to put in there when they fracture. The whole spectrum of nuts, bolts, screws, plates, replacement parts that you might imagine. And we try to use what's really appropriate. Occasionally we get creative. This is a patient I saw as a resident at the VA, metastatic lung cancer. We rotated 2 at a time in the orthopedic program then, and my mate was a car buff. He'd just gotten back from Vietnam, and he used to come to work with the distributor from his Porsche, so his wife couldn't drive the car. And when he saw this fracture, he knew what he wanted to do. And those are radiator hose clamps. And this patient, along with some cement and a rod, did very well during his final months, except for the urge to get his oil changed when he passed the filling station. But there is room for a lot of creativity. And on rare occasion, even with advanced metastatic disease, sometimes replacing the part that's involved, and this is a sarcoma and Paget's disease, or literally amputation, and I thought I had one in here, are in order and to be considered. So that is a whirlwind trip through the scope, evaluation, and treatment options available. And there's one other goal I have to dispel here. I was recently in South Africa, and I was told there was a strong analogy between orthopods and some of their indigenous creatures here. They pointed to the small brain, the thick skin, and the fact it charges a lot. And I'm here to tell you I don't charge a lot. And I appreciate your patience, and I'm glad to answer any questions.